So give me a time check. All right, so it's about 1 p.m. So I think we can go ahead and start. So let me take this opportunity to welcome everyone to MRFTT SCI ECHO. This is, I believe, our 40th session, and this is a very special session. I just want to welcome some of our new friends, some of our old friends. Good to see all of you. I am Dr. Gregory Boyce. I am your facilitator for the afternoon. With me is Tessa Galino. She's one of our registered nurses. And that's a welcome to Dr. Edwards, who is our director and our expert at the MRF Hub. I want to give a particular introduction, particular welcome to Dr. Chris Behrens, who is giving a special lecture this afternoon about COVID-19 and all issues surrounding vaccination and vaccine potency, particularly with respect to vaccine response and the new mutants and the use of the vaccine among persons with HIV. Dr. Behrens works at the University of Washington in Seattle, and he also works with ITEC and has been instrumental in many of the didactic sessions at the Jamaica ECHO and global HIV training around the world. So without any further ado, I'll just turn over to Dr. Behrens. Welcome, Dr. Behrens, and thank you so much for the session. I know it's going to be electrifying.
Okay. Yeah, thank you very much for the invitation to do this. Very happy to connect with you all virtually. It's been far too long since I've been able to visit and collaborate with all of you in person. Hopefully that will happen again in the future. I will go ahead and get us started. Hopefully you all are seeing the slides at this point. I am going to be talking about COVID and the vaccines, and I have to give the usual acknowledgments of our funders and sources that are sponsoring this program. I have no relevant financial disclosures. Hopefully by the end of this, you'll be able to review the key features of the Astrazeneca vaccine. I'm going to focus on that because it's the one that's most relevant, as I understand, to be used in the region. I'm going to summarize some of the available data regarding how well it works against the different strains, and perhaps at the end we can save some time for discussion of implications for Trinidad, for Bahamas, for other countries in the region. So let's start with the efficacy and safety profile. The Astrazeneca vaccine comes from a class of vaccines that use a different virus to deliver the genetic material of the coronavirus into the human cells. And then the human cells, in this case our muscles, churn out the relevant antigens of the coronavirus. The immune system sees those, gets trained, and is then ready to respond in case in the future it sees the real thing. So the Astrazeneca vaccine was developed in collaboration with Oxford. It's got a couple different names, but everybody just calls it the Astrazeneca vaccine. It's also been called the people's vaccine because it's relatively inexpensive, and it's also relatively easy to transport and store. And to their credit, the developers of this have committed to releasing the vaccine at cost. And so it is significantly less expensive than other vaccines. It uses a chimpanzee adenovirus to deliver DNA that encodes the spike protein of the SARS coronavirus into the vaccine recipient, and thereby generate an immune response. And the data I'm going to present are basically summaries to date of ongoing trials being performed in the United Kingdom, South Africa, and Brazil. And these data have come out in two papers, one that was actually published in January, and another is a preprint that hasn't been formally published yet, that was posted online just last week. So the vaccine involves 2 doses that are given 4 to 12 weeks apart. Now, the original design was for the doses be given about 4 weeks apart, but as it happened in many, in fact, most individuals, that didn't happen. The period of time between doses ended up being longer than that, and we'll see what the implications are of that delayed second dose are. Also, further complicating the study, there were a subset of participants in the United Kingdom who accidentally received a lower dose of that first vaccination than they should have. They received exactly half the standard dose in that first vaccine. Again, just kind of a mathematical computational error that was made along the line. So when we talk about these results, you'll often see them presented as SD/SD versus LD/SD, where LD refers to the low dose of the first dose of the vaccine, SD refers to the standard dose, whether given in the first or the second. So the primary outcome that was looked at in this study is the efficacy of the vaccine in preventing symptomatic COVID-19 illness after 2 doses. And overall, to date, they are seeing an efficacy rate of about 67%, with a range of anywhere between 57 and 74% for the 95% confidence interval. However, there are various ways to sort of break down the data, and it's worth doing so because we see some significant findings pop out when we do that. For one thing, if we separate out those individuals who got the appropriate standard dose for the first vaccination and compare those to the group who inadvertently got a low dose for their first vaccination, we do see what looks like a significant difference in the efficacy of the vaccine. And sort of surprisingly and counterintuitively, the individuals who received a low dose for their first vaccination actually had a more robust response with higher protection against the vaccine. So patients who, clinical trial participants who received standard dose for both the first and second shots, they enjoyed about a 63% protection against COVID illness, whereas those who got the low dose for the first shot had more like 81% efficacy. Now, the confidence intervals are broad and overlap, but nevertheless, it is suggestive that maybe there's something about, using a lower dose for the first shot that makes it more effective. Now, I also mentioned that while the intent was to have that second dose be given 4 weeks later, that didn't always happen. In fact, many of the doses were given for the second shot as far as 12 weeks or more after the first vaccination. And so if you stratify the data according to the time interval between the 2 shots, you also see a significant difference. And interestingly, the longer the period of time between the shots, the more effective the vaccine appears to be. If you look at all those individuals who received standard dosing for both shots, there's a pretty linear correlation there that you can see on the right-hand side here. With the more time between the 2 shots, the more effective it seems to be. Individuals who had at least 12 weeks between the 2 doses had what appeared to be about an 82% protection against the virus. If you include all the individuals who had low dose initially, followed by standard dose, you get pretty much the same results. A very clear and relatively linear trend. Longer time between the shots, the more efficacy the vaccine becomes. Now, interestingly, those individuals, if you look closely at the numbers, who received the low dose for their first vaccination shot were disproportionately in the group that had a long time between the first and second doses. So it might be that the low dose for the first vaccination wasn't actually the reason why they responded better to the vaccine. It may be simply be due to the fact that those individuals who had low dose initially tended to have a longer period of time before they received the second dose of the vaccine. So the numbers are simply too small to sort of tease out which factor is truly responsible here. But these are the kind of things you may be hearing about. And so I think it's worth trying to clarify what we do know and what we don't know about this vaccine at this time. Now, the investigators looked at a couple of important secondary outcomes as well. One secondary outcome they looked at was severe illness. All the severe illnesses occurred in the placebo group. And so this vaccine was 100% effective in preventing severe infection and preventing death. I think very helpfully, the Astrazeneca vaccine trial designers decided they wanted to look at asymptomatic infection as well. And so what they did is they asked the participants in the trial to do weekly swabs of their noses and the samples would be sent in for PCR testing to see if the virus could be detected. And of course, they also completed symptom screening. And the whole point of this is to figure out, okay, not only do we want to know how well does the vaccine prevent symptomatic illness, but how well does it prevent people from getting the infection, not knowing they have it, and potentially spreading it to others. So we're essentially trying to see, does this vaccine not only prevent illness, but does it also prevent transmission? And most vaccines do both. They reduce both illness and they reduce infectivity. But there are a few examples of vaccines that don't really accomplish this. They might protect against illness, but they don't really do much to prevent an individual from getting asymptomatic infection and transmitting to others. So what they found, broadly speaking, overall, it appeared to confer only about a 22% efficacy in terms of preventing asymptomatic infection. However, again, when they separated out the low dose vaccine recipients versus the standard dose recipients, you saw a pretty dramatic difference in that those individuals who received the low dose for their initial vaccine, they saw about a 50% reduction, basically cut the risk in half of having asymptomatic infection, as compared to only 2%, virtually no protection at all for those who received the standard dose. Now, again, numbers are small, confidence intervals are pretty broad. There's the confounder of the period of time between the two doses that could potentially explain this difference. But nevertheless, I think we can say it looks like this vaccine does provide some efficacy against asymptomatic infection and ongoing spread to others, but certainly not 100%. Now, in terms of safety profile, this looks like it's to be a very safe vaccine. And there's really very little disagreement about this. Across all 4 studies, it had a very good safety profile. Serious adverse events were very well balanced across the study arms. So amongst participants, you saw relatively equal numbers of serious adverse events. In fact, you saw a few more in the control group as compared to the active group who received the actual vaccine. Similarly, if you look at significant or serious events, there are 175 events, slightly more in the control group than in the COVID vaccine group. And it's worth noting that for the control group, they didn't actually use a placebo, they used the meningococcal vaccine, which I think is appropriate because you're using another vaccine, but which protects against something else in order to evaluate safety and efficacy. So of the severe events, there was a case of hemolytic anemia that occurred. This was in someone who received the control vaccine, the meningococcal vaccination. There was a case of transverse myelitis, and this sort of made the news, that occurred 2 weeks after the second dose in an individual who did get the actual Astrazeneca vaccine. It was deemed possibly related to vaccination. There was an independent review committee that concluded, yes, this is probably idiopathic short segment spinal cord demyelination or transverse myelitis. Two additional cases of transverse myelitis were also reported, but later determined to be unlikely to be related to vaccination by an independent committee of neurologic experts. Now, there's also been a question about what ages, should there be an age cutoff for this vaccine? And this is an issue because there were relatively few older individuals in these trials. In fact, only 12% were older than 55 years across all the trials. And there were no individuals over 55 years of age who received that low dose followed by standard dose dosing, which was the most effective. So there's kind of a lack of evidence here that has prompted the European Medicine Agency, for example, while they approve it for all age groups, other countries in Europe sort of disagree. And for example, France has recommended it not be used for people over 65. They want more evidence first. Many other European countries have taken a similar position. A few countries are using a cutoff of 55. Switzerland, again, they like to be independent. They actually haven't approved it for use at all. They want more data. However, the UK, a number of other countries have approved it for use in all groups, basically arguing that absence of evidence is not evidence of absence. While we don't have solid data regarding its effectiveness, we have zero data to suggest it's not going to be effective in older individuals. And in fact, there are sort of in vitro data using proxy markers for immune system response to the vaccine that were performed in older individuals and suggest that those older individuals do have a robust response to it. Now, there really is no disagreement between any of these health agencies regarding the safety of the vaccine. So all of them, feel like it's safe to use for anyone over 18 years of age. Another difference that came out, interestingly, from these trials was that it seems to have a different level of efficacy in different parts of the world. So in the United Kingdom, for example, overall, in that trial, the efficacy was only about 55%, whereas it was 71% in Brazil. And it's very possible that this is due to it being a bit less effective in individuals who have the new UK strain that is recently sort of taken over the circulation of the coronavirus in the United Kingdom. It seems to be about 10% estimated less effective against the UK strain as against the sort of predominant circulating strain elsewhere in the world. Now, more worrisome is a kind of a dramatic drop in its efficacy against the strain that has emerged from South Africa. There's only about 10% efficacy against that strain that has been recently reported. Now, this was a small trial, but that low efficacy in terms of preventing mild to moderate illness led the South African government to actually halt deployment of the vaccine. However, it should be noted this does not rule out the possibility that this vaccine may still protect against severe disease or reduce transmission. These trial participants in the small sub-study were relatively young, unlikely to become severely ill, so it was really impossible to assess its level of protection against severe hospitalization, severe illness, hospitalization, or death. It's also possible too that the vaccine could make people less infectious, even if it doesn't stop them from getting a severe illness itself. So there's a few other questions that we should consider. how much immunity, for how long will the immunity last? We talked about the impact of transmissibility and how effective is it in people with HIV. So in terms of how long, how durable the immunity is from this vaccine, I mean, we really won't know for sure until we get a much longer period of follow-up of these individuals who've had it. So it's too soon to say really for any of these vaccines how durable the response will be. However, we do have proxy markers of immunity, such as serum antibody levels. The data that we have from the Astrazeneca vaccine are promising. These are levels of antibody titers following the first dose. And whether it's the low dose or the standard dose that was received, you see really a prolonged, sustained high-level antibody titer extending all the way out to about 6 months after that first dose. So, so far so good, but only time will tell for sure. Again, does it prevent transmission to others? As I showed earlier, it looks like it probably does, not certainly not 100%, but it has some impact in reducing. There are similar data, again, very small numbers from the Moderna vaccine, also suggesting that it may reduce infectivity, although not 100%. Now, how well do these vaccines work for people with HIV or other immunocompromised individuals? It's kind of too early to say. To their credit, these clinical trials have tried to enroll people with HIV, but we have very few reported data so far about how well they work. The one exception is the Novavax vaccine has been reported to be 60% effective in a UK population without HIV versus 49% effective in those with HIV. So a subtle difference, not huge. I'm not sure that's even clinically, or I'm sorry, statistically significant. But ultimately, we just have to see what we get from the other trials and as we get more data. Certainly, we see no contraindication to using this vaccine in people with HIV. While it's possible it might be slightly less effective, we have no reason to believe it would be, let's say, more dangerous in people with HIV. All right, now I touch on these new variants, and I think it's worth talking a little bit more about them. It's worth noting that mutations in the coronavirus and new strains of this coronavirus are not a new phenomenon. And in fact, we saw this happen approximately 1 year ago when a new version of the coronavirus emerged that involved specifically a mutation in the spike protein in which amino acid aspartate was replaced by amino acid glutamate at codon number 614 in the region that codes for the spike protein. It's interesting that the nomenclature and, that we use for describing these mutations in the coronavirus is exactly the same as what we use when we talk about mutations in HIV. You have a letter standing for the amino acid in question. You have a number standing for the codon number within the gene in question, and then the second amino acid is represented by the second letter is what the mutation resulted in. So it's thought that this mutation made the virus more transmissible, estimated around maybe 10%, but just that 10% improvement in transmissibility and infectivity has led it to sort of displace the older version. And this is the strain that is now circulating worldwide. Essentially, all of it has this mutation in it. However, more recently, we have seen the emergence of new strains with multiple mutations in them. It was first picked up in South Africa in late October. A sort of similarly strange outbreak in Kent, England in mid-December prompted investigators to look there and discover that they had found a also a newly mutated version that had evolved completely independently of what evolved in South Africa. And the mutations that these variants have are thought to enable them to latch on more successfully to target receptors. They bind more efficiently. They generate higher viral loads in the respiratory tract, which probably improves their infectivity to others. And some of these mutations also appear to help it evade the immune system and antibody responses, which is probably why we're starting to see some evidence that some of the vaccines may not work quite as well against them. Each strain is estimated to be roughly 50% more contagious. And that is actually a pretty significant amount, as we'll see. So this is a picture of the coronavirus on top. Emerging from the coronavirus are these spike proteins shown in gray. They're surrounded by glucose molecules in dark blue. And at the very tip of each of these spike proteins is the part that actually attaches to the receptor on the surface of an epithelial cell. The receptor being the ACE2 enzyme, which is shown in yellow and red on the bottom. And so mutations in the spike protein, and especially in that light blue portion, which is abbreviated as RBD, are what seem to be giving the virus these advantages. So if we sequence the genome of the coronavirus, it's about 30,000 base pairs long. The UK strain, also known as B117, has accumulated a number of mutations, mostly in the portion of the genome that codes for the spike protein, that seem to be very relevant here. And those mutations gave it quite an advantage. And while it started out with a rather slow growth, what you saw over time throughout the course of November and December was this new variant kind of taking off and displacing the prior circulating variant in the population in the United Kingdom. And it led to quite a spike in infections there. Ireland was especially hard hit. They seemed to have the coronavirus really under control until this new variant entered the population, and then infections just took off. And it prompted Tom Frieden, he was a former director of our Centers for Disease Control here in the United States, to say, I've never seen an epi curve like this. The B117 variant is spreading like wildfire in the UK and Ireland. If it spreads here, meaning the United States, it will make an already bad situation even worse. And indeed, it has arrived in the United States, and it is starting to spread. The modeling estimates are that this will become the dominant circulating strain in the United States, probably sometime in late March, about a month from now. Now, the South Africa strain is even potentially more concerning. This was identified in the Eastern Cape region of South Africa. It's spread in many countries around the world. This is a little dated. It has spread to the United States as well. We picked it up in South Carolina and one other state. And this too, shortly after its emergence, really took over and became by far the dominant strain in South Africa. And it's probably not a coincidence that it developed in the Southeastern Cape region, because this is a region where there is a very high number of untreated HIV infection. And it would appear that infection in an immunocompromised host allows the coronavirus more replication cycles, more time to evolve mutations, because the host immune system is not so good at clearing it. And so it's thought that this new strain probably evolved in one or more individuals with advanced HIV whose immune systems really couldn't respond well to the virus, allowed the virus to evolve more and develop these more mutations and then spread to others. You may have also heard about a variant in Brazil. This has quite a few mutations as well, many of which overlap with the ones in UK and in South Africa. Again, it evolved completely independently. In fact, it showed up in a city in Brazil, Manaus, which is deep in the Amazon jungle. And it was a city that had already had a very large wave of COVID-19 pass through it. It was thought that that population had about 75% already infected. Hence, there should be herd immunity in that city. That's the last place you would expect a new sort of wave of the virus to pass through. Nevertheless, Manaus was hit very hard by this variant. Very high numbers of people infected, suggesting that prior infection with an earlier strain of COVID did not protect against infection with this new strain, reinforcing the idea that some of these mutations must be helping the virus to evade the immune system and evade immune response. So, what are the implications? Well, everywhere that these have occurred, the new strains have rapidly become the dominant strains and have led to a tremendous spike of infection. And this can have really profound impact on the epidemiology. So let's say, for example, let's just use kind of a mathematical model here. And let's say we have a community where you have a very consistent 1,000 cases per month of the COVID illness, okay? And this is neither growing nor shrinking. In technical terms, our reproductive rate is 1. Things are very stable. Now, if you introduce a new version of the virus that is 50% more infectious, which is what the South African and British strains are estimated to be, suddenly the epidemic takes off. In 1 month, rather than having your usual 1,000 cases, all of a sudden you've got 10,000 new cases. So a very dramatic impact just from having a strain that's more infectious. It has a very big impact on mortality as well. Again, similar model, you've got a community with now 10,000 infections, let's say, and let's assume a 0.8% case fatality rate, which is a pretty good estimate of how COVID behaves. In 1 month's time, you'd expect about 129 deaths in that community. However, if you introduce this new strain that's 50% more infectious, even without any change in the sort of lethality of the virus, you see an explosion in the number of deaths just due to the explosion in the number of cases and people who are getting infected. So after 1 month, instead of 129 deaths, you have 978 deaths. So this is what has epidemiologists and public health officials so worried about these new, more infectious strains. Now, where did these strains come from, and what can we do about them? Well, as I mentioned, it looks like the strains in South Africa came from the Eastern Cape, where there's a lot of untreated HIV. It seems very possible, if not likely, that that's where these strains evolved. There was an interesting case published in the New England Journal several months ago, which didn't attract a lot of attention at the time, but is now. It involved a patient there who was immunocompromised, in this case not by HIV, but by a different condition called antiphospholipid antibody syndrome. That individual stayed in the hospital for many weeks, and researchers decided to sequence the virus in that individual over time. And what they saw over the course of his hospitalization was the evolution of quite a number of, frankly, frightening mutations in the virus. Now, that individual passed away, didn't make it out of the hospital, but it was kind of proof that this can happen in immunocompromised individuals. And it's probably what happened in South Africa. In Britain, the outbreak there, they think they've traced it to just 2 or 3 individuals who were treated in the hospital, had prolonged stays, and who received convalescent plasma containing antibodies from individuals who had already had COVID. And they think that that convalescent plasma may have exerted just the right amount of sort of evolutionary pressure to prompt the virus to develop mutations. Then those individuals recovered, they left, but they were still, unfortunately, infectious, and they ended up transmitting their mutant strains to others. And that's probably how the whole new strain started in Great Britain. All right, so I think what that underscores, honestly, is the importance of getting everybody vaccinated, including and maybe especially our individuals with HIV, because immunocompromised individuals may be at higher risk of promoting the development of these mutations that make the virus more dangerous. Now, how well do our vaccines work against these new strains? That's a huge question. As I mentioned, the Astrazeneca vaccine seems to be only about 10% effective in preventing mild to moderate COVID-19 illness against the South Africa strain. There's been a couple other vaccine makers that have also examined this. They have also seen a drop in efficacy against the South Africa strain. Similarly, there seems to be a drop in efficacy against the United Kingdom strain, the UK strain, although probably and perhaps not as severe. So I have tried to kind of summarize here the efficacy of these vaccines as far as we know against different strains. And I think the most relevant one for the region is the performance of the Astrazeneca strain. Its efficacy to date in the trials, 67% overall, but 55% in the UK, probably owing to the emergence of that mutant strain and some of the vaccine recipients. 71% in Brazil. Again, that was before this new strain evolved in Manaus, so we're not taking that into account, but only 10% against the South Africa variant. And again, you see some similar pattern where it's been studied elsewhere. So what can we do about it? Well, our vaccines can be modified to meet the challenge of new strains. Oxford/AstraZeneca is already working on developing a new version that would be able to accommodate this new strain from South Africa. It should not take nearly as long to do it as it did to produce the vaccine in the first place. Moderna and Pfizer use a different technology. This messenger RNA technology they use also allows for relatively rapidly pivoting to make a new version. Think of it as a booster shot to protect against newer strains. But you can see how this is kind of a race, between the coronavirus evolving these new mutations to avoid the immune system. We may be constantly trying to play catch up and fine-tuning our vaccines with boosters to try and address those. But there's always going to be this ongoing challenge in terms of the logistics of getting these new booster shots out to people. It's been hard enough just to get the original versions out. So I think I'll stop now because I want to leave plenty of time for discussion. And so I'm going to open it up to questions and discussion.
Thank you, Dr. Behrens, for that really, really interesting conversation about all things COVID and COVID vaccine. So anyone who has a question, just raise your hand or type a question in the chat box if you don't have access to a microphone. I guess while everyone is sort of getting themselves warmed up. if I may take the prerogative and start the first question, there was some question in the scientific community when I was sort of doing some reading about the Astrazeneca vaccine and the adenovirus platform around concerns regarding the risk of HIV acquisition among persons at high risk of acquiring HIV because of a previous vaccine trial that had shown with a certain adenovirus, there was an increased risk of acquisition of HIV. So even though the Astrazeneca vaccine didn't use that particular adenovirus, there was a question about adenoviruses in general, potentially potentiating risk of vaccine HIV acquisition among persons who are vaccinated. Could you just comment very briefly on that?
Sure. I'll comment what I know, which isn't much, other than I've heard. I know what you're talking about. There was a candidate HIV vaccine that was produced many years ago, which used a similar technology as this Astrazeneca vaccine. It used a certain kind of adenovirus to try to bring HIV genetic material into the human body, thereby getting the recipient to generate an immune response to that. Hopefully would fight off HIV if it saw the real thing. Unfortunately, it looked like what that vaccine did was actually somehow predispose recipients to be more susceptible to HIV infection. So having got the vaccine, it looked like they were actually more likely to subsequently get HIV as opposed to less likely. Very paradoxical, very unfortunate, and rather unexpected, of course. So given how, kind of mysterious that was, the concern is, well, here we are using a similar technology for a new vaccine. Could it potentially have that same effect, rendering the recipients actually more likely to acquire HIV? I mean, I don't think we have any data yet really to go by. It seems like a very highly theoretical thing. And I think the strongest argument against that happening would be the fact that, well, this vaccine carries nothing related to HIV in it. Having said that, what was it about that HIV vaccine? Was it something about the HIV itself, or was it something about the adenovirus that was used to introduce the material? All I can say is, the trials of these vaccines, they passed the ethical review boards, they passed the regulators, they were allowed to recruit people with HIV. And I'm not aware of any data to date suggesting that it does render people more or less, prone to HIV. But of course, these are early days, and this probably would be too soon to know for sure. I would say on balance, the benefits of this vaccine, really all of these vaccines far, far outweigh this potential theoretical risk. But it is a reasonable question and concern.
Thanks so much for that, Dr. Behrens. We have some questions in the chat box there. The first question comes from one of the nurses at MRF. Would you recommend vaccinating HIV clients who are virally unsuppressed, even if they do not have another underlying illness?
Would I recommend? I would recommend anyone with HIV to get this. Regardless of whether or not they're suppressed and regardless of whether or not they have underlying illness. I mean, I just think, we've seen how bad COVID can be. We know that people with advanced HIV disease tend to have a worse course of it. So, of course, you want to get, for someone with HIV, probably a higher priority to get their HIV under control. That's going to be a bigger benefit to their health. But I don't think that should necessarily interfere with getting the vaccine. Again, we don't have a whole lot of data about its efficacy in people with HIV. It looks like from the data we do have, it is effective, maybe slightly less so. But I see really no reason to defer giving it to people with HIV. I hope that makes sense. And I'm gonna share. I had a better summary slide regarding the variants and the impact of the vaccines. So I'm just gonna put that up there while we field questions.
We have another question. Is there a limit for CD4 count for PLHIVs if they are to receive the vaccine?
I'm not aware of any limit. I think on a theoretical basis, you might expect the vaccine to be more effective in individuals with higher CD4 counts, less effective in those with low CD4 counts. But we have no data to date suggesting that, demonstrating that. And again, I would not, I have not seen any guidance to that effect, and I would not withhold it from people with lower CD4 counts.
We have two questions coming in from Dr. Edwards. After vaccination, if one travels to another country, does one have to quarantine? And Barbados receives a supply of Astrazeneca vaccine from India. Have these vaccines been approved?
So quarantine, I mean, that's something I can't really, it's up to national policymakers. I don't know what the rules are. I think different countries might have different procedures and policies on that front. The Astrazeneca vaccine, I don't know actually exactly where it's being manufactured, et cetera. I have not heard about any concerns about the quality control problems anywhere it's being manufactured. So I would see no reason to doubt it just based on where it came from.
Question from within the room. In terms of age, so the vaccines would have been, but this vaccine in particular, but the data would have been on persons 18 years and over. What about persons younger than that, especially persons living with HIV?
Yeah. So it's been frustratingly slow to get data on children and adolescents as to how effective and safe these vaccines are. I don't think they are authorized at this point for use in any of the vaccines are authorized for use in children or adolescents anywhere because we just don't have the data. Now the data, we will get some data. I mean, I know there are clinical trials underway. I don't know when we'll get that information. So I think we just have to wait.
For that, another question. So one of the issues that came up, I think, sort of listening to the coverage about this virus and the rollout of vaccines, in terms of how flu vaccines are, where there's an annual flu shot that you have to get because every year these strains change and change. Do you, at least given how this virus is behaving early on, just a year later on the mutations, we have to change the vaccine products to accommodate those new mutations. Do you foresee that as a possibility, where people maybe have to get a COVID shot every year because the predominant strains keep changing all over the place?
I think it's conceivable, yes. Yeah, we could be looking at a situation like that. Now, the vaccines that we have seem to be a lot more effective than the flu vaccine. And so, I mean, conceivably, we could vaccinate enough to really reduce the amount out there to the point where it doesn't mutate so much. However, that seems a bit unlikely. That seems perhaps overly optimistic. And I think what you're describing is a real possibility, although I have to say I'm not, I don't speak from any special knowledge. You know, a vaccine specialist would probably be able to better answer that question than I would.
And so just another question sort of from me. So the vaccine rollout would have started in the US already, and you would have been, you know, I suppose at your site would involve in some of that vaccine rollout. Is there anything that you found unexpected, essentially from an experiential point of view, in terms of the process of vaccine rollout and the response to the vaccine rollout? Because we haven't quite started rollout in Trinidad as yet, and in most of the Caribbean. If you had to tell us one or two things to look out for with respect to the rollout of the vaccine, what surprised you?
Okay, yeah, good. I guess one thing that surprised me is there have been you know, to me, a surprisingly high number of healthcare workers who have declined to get the vaccine. And that, I was a little surprised by that. Because to me, you know, it just seems like such a clear-cut case that the benefits outweigh the risks associated with these vaccines, given what we know so far. There are various ways to talk to healthcare workers about that. I think it is worth acknowledging that these vaccines were developed in sort of record time. It's actually pretty amazing how quickly these vaccines came out. It's also astounding how overall, how effective they've, for the most part, turned out to be. But you know, they didn't have as much of a follow-up period as we usually want for vaccines. And so where they've been authorized, it uses language like in the United States, emergency use authorization, EUA, recognizing that we really can't comment on possible long-term, maybe some side effect will pop up, you know, many, many months later. That seems extremely unlikely, but we can't rule it out because we just haven't followed up on it so long. So when it comes to, you know, talking about this with people who have reluctance, I think it doesn't work to just say, oh, no, you're wrong. You need to get this vaccine. You really need to engage in a discussion and explore what the hesitancy is and see, well, you know, what might change your mind? You know, if we had more data, would you feel more reassured? Would that prompt you to get it? Because we will get more data, you know, we will get more safety data coming in steadily from all these vaccines. So I think that's helpful. I would say another thing that occurred here, which actually not all that surprising, is that it's been kind of chaotic. And this is kind of something inherited from, in large part from the prior administration, which really didn't have a plan developed for how to roll out the vaccination process, and absolutely no federal coordination whatsoever. So it's been up to individual states and counties and facilities to try and navigate acquiring the vaccine, distributing it, prioritizing certain groups over other groups. How do you enforce that? How hard do you try to enforce that? These can be kind of thorny questions because at any given time, you're just not going to have enough supply to meet the demand, at least for the foreseeable future. So you're going to have to prioritize some groups over others. So I guess those are the two things I would cite.
We have more questions coming up. If someone got COVID-19, do they need to be vaccinated? And can the Astrazeneca be given to pregnant women?
Right, good question. So I would say we do know it's been pretty clear from all the studies to date that natural infection does not confer as much protection, as strong immunity against the virus as do the vaccines. The vaccines actually do a better job, provide stronger immunity than does natural infection. So if I had COVID, I would go ahead and get the vaccine. We do know that people can be reinfected, and not necessarily, it doesn't necessarily have to be like a totally different, mutant strain, although we're seeing that happen as well. So yes, I think people should. Having natural infection provides some protection. It's hard to say just how much, but I think that vaccine is going to give even more and is worth getting. As far as pregnancy, really not a lot of data so far. We're not aware of any, adverse side effects in the vaccine among women who are pregnant. However, what we do know is that pregnant women have a much harder time with COVID. They are far more likely to have severe illness and far more likely to die from COVID than are non-pregnant women, probably owing to the immune system changes that take place during pregnancy. So to me, that just underscores the importance of doing everything you can to protect yourself against getting this while pregnant. And so my take is that it's probably better to get the vaccine than not get the vaccine if you're pregnant, if you are at any risk of getting the virus itself. Obviously, we hope to get more data coming out, but I think these vaccination trials excluded pregnant women. Of course, as always happens, some women slip through the cracks. They're pregnant, didn't know it at the time they enrolled. And so we have a little bit of data, but I'm not aware of any data suggesting increased risk of the vaccine in pregnancy.
For PLHIV, so on ART, will there be any drug interaction or like negative side effects in their taking the vaccine?
No drug interactions, no. There's no problem there. I don't think the HIV meds at all complicate the situation. The side effects, AstraZeneca, the papers that have been released on this have just not had a whole lot of detail regarding the side effects, other than, it's very uncommon, get severe side effects, and they don't seem to occur more commonly in vaccine recipients versus control. What we have seen with other vaccines is not uncommon to get local side effects like soreness, or redness or swelling where the vaccine was administered. And with the Moderna and Pfizer vaccines we've been using here in the United States, not uncommon to have kind of a febrile, almost flu-like syndrome for 24 to 48 hours afterwards. Doesn't occur in most people, but can occur in some. Sure, that could, I wouldn't be surprised if we see that happen with AstraZeneca. If anything, we've seen that if the immune system is depleted somehow, you're less likely to get those reactions, because of course those reactions are due to the immune system responding to the virus.
We have another question. Is it recommended that we do a pilot for a general population in light of what little information there is?
So in other words, do a study of AstraZeneca vaccine locally before rolling it out? I guess that's what you're wondering, what the question's getting. I wouldn't recommend that. I mean, the problem is it introduces quite a bit of delay. I mean, any study that tries to assess the efficacy of this vaccine in a given population is going to take several months. And furthermore, if you're doing it, I mean, in Trinidad, the numbers are relatively small, broadly speaking, as compared to these huge trials that were done in multiple countries. So I think it would take way too much time to accumulate data regarding the effectiveness of the vaccine, specifically within Trinidad. And in the meantime, you're not immunizing people, and furthermore, you have no reason to believe it wouldn't work in Trinidad as it has worked, in other parts of the world, where everywhere it's been tested, it has at least provided some benefit, with the exception of this new South African strain, which my understanding is you have not seen that at all in Trinidad.
So I'm not seeing any other questions right now in the chat box. So I think I'll turn you back over to Dr. Boyce.
Thank you. Just probably squeezing, but just about a minute over time. Just one quick final question. In terms of the data with respect to efficacy among persons with HIV, just as a reminder, how robust is the data in that area?
Not very robust. There's only one study that I found that had any information about how well it works in people with HIV, and that was the Novavax trial, or Novavax vaccine, I should say. They reported in a subset of people with HIV is 49% effective in preventing symptomatic COVID illness, as compared with 60% in a cohort without HIV. Now, I have not seen them mention, I have not seen, any more detail than that. So I don't know if those confidence intervals overlap. I don't know how big the numbers are. I don't know, the people with HIV, were they on ART or not? Were they virologically suppressed? What were their CD4 counts? Was there any difference in mild versus moderate versus severe disease? And I think we're just going to need more time. So the data are not robust at all, but the data we do have, that's kind of reassuring that at least what we have shows a pretty small drop in efficacy for that particular vaccine.
Thank you very much for that. So I think they're just going to be mindful of time, but just a bit over time. So again, thank you, Dr. Behrens, for that, for this wonderful presentation. I think it answered a lot of questions, both among the staff and other persons who are responsible for coordinating the vaccine response. I just want to thank all the persons who came and who participated and who asked all those very, very good questions. So a small housekeeping note, our next session will be back on a Thursday, again, Thursday, 25th of February at 2 p.m. Trinidad time. We will be having another MRFTT STI echo session at that time. Thanks so much for your interest, and we hope to see you back then. Everyone take care and be safe.
Thanks very much.
Thank you. Great session.
Thank
Thank
you.
you.